I'm Carla Pecoraro.
I'm Millie Kamen.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound Podcast, bringing you up-to-date information in all things ONG. This week, we're talking about one of my favourite topics, gestational trophoblastic disease, otherwise known as molar pregnancy. Now, when we say gestational trophoblastic disease, or GTD, what do we actually mean?
Gestational trophoblastic disease is actually an umbrella term for a group of diseases characterized by autonomous overgrowth of fetal chorionic tissue or trophoblast. Basically, it's a tumor of placental tissue. It includes pre-malignant disorders like partial or complete mole, and placental site nodule and malignant disorders, which include invasive mole, choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. These malignant conditions tend to be referred to as gestational trophoblastic neoplasia, or GTN. This week, we'll cover the pre-malignant conditions, focusing mainly on partial and complete molar pregnancy. So, let's start off with a case.
Okay, so today we're seeing Jemima. Jemima is a 40-year-old G2P1 at 6 weeks gestation based on her last menstrual period. She presents today with mild cramping, lower abdominal pain, and vaginal bleeding. Jemima has had a horrible pregnancy so far with severe hyperemesis. On examination, she looks well with normal observations. Speculum exam shows a closed cervix with a small amount of old blood in the vault. Biomanual reveals a bulky uterus consistent with a 10-week gestation. Her beta-HCG is 150,000. What features in Jemima's history and examination would alert you to the possibility of a molar pregnancy?
Bleeding in early pregnancy is a very common presentation, and although it is associated with molar pregnancy, you can also see it with miscarriage, threatened miscarriage, and ectopic pregnancy. For me, the red flags are significant hyperemesis, excessive uterine enlargement compared to her dates, and a beta-HCG of over 100,000. These are some of the presentations that we tend to get with molar pregnancy, although again, you can also see this with twins. At this point, I'd really be wanting an ultrasound to help narrow down the differential diagnosis.
Before we move on to the ultrasound findings, what are some of the other clinical features of a molar pregnancy?
Well, as Mel said, the most common presentation of molar pregnancy is irregular bleeding with an excessively high beta-HCG and abnormal ultrasound findings. Less common features include hyperemesis, excessive uterine enlargement, hypothyroidism, early onset preeclampsia, and abdominal distension due to theca lutein cysts. Very rarely, women can even present with hemoptysis or seizures due to metastatic disease affecting the lungs or brain.
Okay, now that we understand some of the clinical features of molar pregnancy, let's move on to the ultrasound findings. The classic ultrasound appearance of a complete mole is a snowstorm appearance. This basically looks like multiple cystic structures or a bunch of grapes within the uterus. We'll put a picture up on our Instagram summary slide so you can have a peek. A complete mole will have no embryo or amniotic fluid and may be associated with ovarian theca lutein cysts.
Wait, what's a theca lutein cyst?
A theca lutein cyst is basically a large multicystic ovary that tends to occur on both sides. They are thought to occur because of exaggerated physiological stimulation of the ovarian theca cells by high levels of beta-HCG. The Latin name, are you ready for it? Hyperreactio luteinalis.
Right, okay. Sounds like me on my periods. Hyperreactive.
Great joke.
The cysts don't usually cause a problem unless they rupture or tort and typically go away once the molar pregnancy is terminated. Very, very rarely, theca lutein cysts can produce massive ascites. They can also cause maternal virilization, leading to a deeper voice, facial hirsutism, and hair loss seen during the onset of pregnancy. Theca lutein cysts are classically associated with GTD, but they can also be found in multiple pregnancy, placentomegaly associated with diabetes, anti-D isoimmunization, or women undergoing fertility treatment with HCG or clomiphene.
Okay, all right, we digress. Let's get back to Anne and the ultrasound findings of molar pregnancy. So we spoke about the ultrasound features of a complete molar pregnancy. What might we see with a partial mole?
Unlike a complete mole, a partial mole does contain fetal parts. If the pregnancy progresses, you would expect to see a growth-restricted fetus with reduced amniotic fluid, as well as a placenta with enlarged cystic spaces. In most cases of partial mole, the embryo is not viable, so you might not be able to see it. Partial molar pregnancies do not have ovarian thicker lutein cysts. Now, we can't always tell the difference between a partial mole and a complete mole on ultrasound. Sometimes the fetal parts aren't visible or the pregnancy ended very early. The only way to know whether the pregnancy is a partial or complete mole is through histopathology and genetic testing.
Okay, so back to Jemima. You send Jemima for an ultrasound scan and the report comes back with an enlarged uterus with a snowstorm appearance and no visible fetal parts. The conclusion says likely molar pregnancy. How would you explain this diagnosis to Jemima?
So, I would start by explaining that a molar pregnancy is essentially a benign tumour of placental tissue. Basically, there's an error with fertilisation, where normally you would have one sperm fertilising one egg to create an embryo. With a molar pregnancy, you either have two sperm fertilising one egg or two sperm fertilising an empty egg. This results in a partial or complete mole, respectively. The problem with a molar pregnancy is its potential to become malignant, invade the uterus, and metastasize. For this reason, it's important that we remove the pregnancy and perform adequate follow-up.
So I guess Jemima's first question is, why did this happen to me?
This is a really difficult question to answer. We don't know exactly what happens to trigger the abnormal fertilization. That said, though, there are a few risk factors that increase the chances of having a molar pregnancy. These risk factors include age less than 15 or more than 35, a previous molar pregnancy, low dietary carotene, animal fat, or vitamin D, a history of previous miscarriage or infertility, Asian and American Indian ancestry. Weirdly, you can also get familial clustering and recurrent mole called familial biparental recurrent moles due to mutations of certain genes. These moles are a bit atypical as they are diploid but carry genetic material from the egg and sperm, hence biparental.
Jemima says she's never heard of this before, and she wants to know if molar pregnancy is really common.
In general, the incidence of molar pregnancy is about 1 in 1,000, but there is some ethnic variation. The rate of molar pregnancy is doubled in women of Asian and American Indian descent. The incidence of molar pregnancy is also associated with extremes of age. In women under the age of 15, the incidence of 1 in 500, and in women over 50, the odds of a molar pregnancy are about 1 in 8.
Wow, there you go. All right, so we've diagnosed a molar pregnancy and explained the diagnosis to Jemima. What's our management plan?
Once we've diagnosed a molar pregnancy on scan, the next step is to arrange a suction D&C to evacuate the uterus. This is really important because we want to make sure we remove all of the pregnancy tissue, but we also want to make sure we collect the tissue and send it to the lab. This is so we can work out whether the pregnancy was a partial or complete mole, because our follow-up plans are slightly different depending which type of molar pregnancy we have. Now, the suction D&C procedure is exactly the same as what we might do for surgical management of a miscarriage or termination of pregnancy, but with a molar pregnancy, there is a slightly higher chance of bleeding. For this reason, we recommend a large bore cannula, a full blood count and group and hold, as well as being prepared for additional management strategies, such as a Foley's if bleeding is severe. We also recommend using ultrasound guidance to ensure the uterine cavity is empty.
Molar pregnancies can also be associated with metastatic disease and a thyroid storm. So it can also be a good idea to arrange TFTs, liver function tests, and coags before the procedure. A chest x-ray might also be indicated if there are any respiratory symptoms. Cervical priming with misoprostol is safe, but the use of oxytocics should be avoided until the uterus is empty. This is because of the theoretical risk of embolizing pregnancy tissue into the maternal blood flow, resulting in metastatic disease with the use of oxytocics.
What about if Jemima doesn't want a D&C? Could she have medical management instead?
Medical management of a molar pregnancy is not recommended. Not only is the failure rate higher, but medical management actually increases maternal morbidity and the development of gestational trophoblastic neoplasia requiring chemotherapy. In a review of 4,247 women with GTD, the risk of developing GTN and requiring chemotherapy was 16 times higher when medical methods of removal were used compared with surgical removal.
Okay, well, what if Jemima doesn't want future fertility? Can she just have a hysterectomy?
Actually, yes, this is a reasonable request. If a woman has completed childbearing and does not want to undergo prolonged follow-up with beta-HCG monitoring or take the risk of progression to GTN, then she can consider a hysterectomy. Hysterectomy eliminates any locally invasive disease and reduces the chances of developing GTN, but it doesn't prevent all cases of metastatic disease. In some patients, they may already have occult metastatic disease before they have the hysterectomy.
And what would happen if Jemima did nothing? She said, "No, thank you. I don't want any management. I'm just going to let nature take its course."
Well, that situation would be extremely ill-advised and is very uncommon. A molar pregnancy is likely to continue to grow and inevitably leads to severe hemorrhage, which can result in the need for blood transfusion, hysterectomy, or even death. There are case reports in the literature of molar pregnancies progressing to a term-sized uterus and eventually presenting with severe hemorrhage. Allowing the molar pregnancy to grow also increases the risk of GTN and metastatic disease.
Alrighty, so suction D&C it is. What exactly should we order when we're sending the pregnancy tissue to the lab?
The tests you should order include histopathology, ploidy studies, and P57 staining. Because this testing involves cytogenetics, it's important that we send the pregnancy tissue fresh and not in formalin. Remember, formalin can cause DNA mutations and affect our cytogenetics results, so we really want to avoid that. Histopathology is usually performed to identify the typical features of molar pregnancy. These include hydropic villi, villus trophoblastic hyperplasia, cytological atypia, and in the presence of a partial mole, either fetal vessels or fetal tissue. If a person is having products of conception sent from a miscarriage, then these are also the kinds of features that would prompt additional genetic testing to check for a hydatidiform mole.
So, does hydropic villi on histopathology always mean molar pregnancy?
Not always. Hydropic villi can also occur with hydropic miscarriage, aneuploidy or metabolic abnormality, or even structural abnormalities. This is why it's so important to correlate histopathological findings with cytogenetics.
Ploidy studies are helpful to work out whether the pregnancy is complete or partial. Remember, a complete mole is whether there is fertilization of an empty egg with 2 sperm, so cells of complete mole are diploid, meaning they contain 2 sets of genetic material. A partial mole is from fertilization of the ovum with 2 sperm, resulting in triploidy, or 3 sets of genetic material, 1 from each sperm and 1 from the egg. Now remember that most normal embryos are also diploid, containing 1 set of genetic material from the sperm and 1 set from the egg. P57 testing helps us to narrow down whether we have a complete or partial mole. With a complete mole, the genetic material is exclusively paternal. P57 is a gene that is specifically expressed by the maternal genome. If P57 is present, the maternal genetic material is present. So that would be the case in a normal diploid pregnancy or a triploid partial molar pregnancy. If P57 is absent, then this means that there is no maternal genetic material. So in a diploid pregnancy, we would know that the genetic material has come from 2 sperm and therefore the pregnancy is a complete mole.
Why is it so important to differentiate between a complete mole and a partial mole?
So, complete moles and partial moles have different risks of progression to malignancy. With a complete mole, there's a 15 to 20% chance of progression to gestational trophoblastic neoplasia. With a partial mole, there's only a 1 to 5% risk. Because of this, we tend to have slightly different follow-up plans for complete versus partial moles.
And what are these follow-up plans?
With molar pregnancies, it's incredibly important that we ensure the molar pregnancy resolves. If the tissue persists, then we're worried about persistent trophoblastic disease or progression to gestational trophoblastic neoplasia. We check for persistence or progression through monitoring the beta-HCG. Serial beta-HCGs are performed to make sure the level goes to 0 and stays that way. The duration of follow-up and testing depends on whether the pregnancy is a complete or partial mole. With a partial mole, remember there was only a 5% risk of progression. For these patients, we repeat the beta-HCG weekly until it's negative for 3 weeks in a row. With a complete mole, we repeat the beta-HCG until it's negative for 3 weeks in a row, and then monthly until it's been negative for 6 months.
Now, I've heard that this recommendation has changed recently. I thought the new Green Top guideline said something different.
Yeah, so the Green Top guideline was updated in 2020, and one of the main things that changed was the follow-up regime. For complete molar pregnancy, if the beta-HCG has reverted to normal within 56 days of the pregnancy, then follow-up will be for 6 months from the date of uterine evacuation. If the beta-HCG has not reverted to normal within 56 days, then follow-up will be monthly beta-HCG for 6 months from normalization of the beta-HCG level. For partial molar pregnancy, you do weekly beta-HCG until the HCG is negative, and then one further HCG 1 month after the first negative test. The reason for this change is that several large case series have shown that once the HCG reverts to normal, the chance of developing GTN is very low. Therefore, a less strict follow-up period is acceptable for most women. This follow-up regime is also supported by FIGO. In Australia, the RANZCOG GTD guideline has yet to be updated. It was due in 2020, but we haven't quite seen the new one yet, and most of the hospitals around Australia are still following the RANZCOG recommendation. Our prediction is that once the RANZCOG guideline gets updated, we expect that will probably change to be in line with ARCOG.
Okay, so we've completed our suction D&C under ultrasound guidance, sent the products of conception for histopathology, ploidy studies, and P57 staining, and given Jemima a bunch of beta-HCG forms to have weekly until negative. We plan a follow-up appointment to check the results of the genetic testing so we can advise Jemima how long she needs to be followed up for. Is there anything else we need to consider before Jemima goes home?
Yes. Have we checked her blood group? If Jemima is rhesus negative, then it's really important that we give her anti-D. Remember, the dose in the first trimester in Australia is 250 international units. Partial moles contain trophoblastic tissue, which can contain the D antigen. There is therefore a small risk of isoimmunization from a partial molar pregnancy. Complete moles, on the other hand, have no fetal tissue, so you won't get expression of the D antigen. Women with complete moles do not need anti-D. The problem with molar pregnancy is that we often don't know if the pregnancy is a complete mole or partial mole for a few weeks. And by then, we've sort of missed the window of effectiveness for anti-D. So anti-D should ideally be given on the day of surgery or at least within 72 hours of the procedure. We tend to give all women with molar pregnancy anti-D to be on the safe side.
We also need to counsel Jemima on the importance of beta-HCG follow-up. Ideally, we'd recommend that Jemima avoids a pregnancy until her follow-up is complete. If Jemima gets pregnant while we're following her beta-HCG levels, it can be impossible to tell whether the beta-HCG rise is from pregnancy or if she's progressed to gestational trophoblastic neoplasia. We do recommend contraception, and the oral contraceptive pill is fine. With the Mirena, there is a higher risk of perforation of the uterus, and so you should wait until at least 6 weeks after the D&C and when the HCG levels have returned to normal before popping that in. If the woman does get pregnant during follow-up, she should be allowed to continue the pregnancy.
The other important thing to do is to refer Jemima to a gestational trophoblastic centre. Women with molar pregnancy confirmed with genetic testing are referred to the GTC and have their follow-up overseen by this team. This results in better outcomes for the women and more rapid access to chemotherapy if there is progression to GTN. It also provides a centralised registry where data can be collected to help us study more the outcomes of women with molar pregnancy. There is no national registry in Australia, but most states have their own GTD registry. In Queensland, this is based at the Royal Brisbane and Women's Hospital. In Victoria, it's at the Royal Women's Hospital. In Western Australia, it's at the WA Trophoblastic Centre at King Eddie's Memorial Hospital, and for other states, you should check with your local gynae-oncology service. New Zealand actually has its own national GTD registry.
Okay, so Jemima takes your advice and completes her follow-up until her beta-HCG remains negative. She's now thinking about another pregnancy and has a few questions for you. Firstly, what's the risk of recurrence?
The recurrence risk after 1 molar pregnancy is about 1 to 1.9%. After 2 molar pregnancies, that rate increases to 15 to 17.5%.
Her next question is whether the pregnancy will be affected by the previous molar pregnancy or not.
Women who fall pregnant after a molar pregnancy are not at increased risk of maternal complications, and in general, they can expect normal pregnancy outcomes.
Jemima also wants to know whether there is anything she needs to do differently with the next pregnancy.
Generally, no. Jemima can have her pregnancy managed routinely. The RANZCOG guideline suggests that women with a previous molar pregnancy should have their placenta sent for histopathology and a serum beta-HCG 6 weeks after any pregnancy. This was one of the other big changes that came out of the 2020 Green Top guideline update. The GTDG now states that women who have a pregnancy following a previous molar pregnancy do not need to have a follow-up beta-HCG or have their placenta sent for histopathology. Now, if the woman has had chemo for GTN, this is a bit different. But for the standard molar pregnancy, the GTG suggests we don't need to send the placenta or arrange beta-HCG follow-up. The reasoning behind this is firstly because the risk of recurrent molar pregnancy is low, about 1%. And secondly, a UK national retrospective evaluation concluded that the detection rate for recurrent GTD on routine post-pregnancy screening of previously uncomplicated molar pregnancy is extremely low and may be safely discontinued. The incidence of GTD in a subsequent pregnancy is very low in women who have not received chemo for a prior molar pregnancy. For now, you should follow your state guideline, but it's important to be aware of different management practices in different guidelines.
Okay, so before we wrap up, we should probably cover some of the tricky scenarios everyone wants to know about. Firstly, what do you do if you do a D&C for suspected molar pregnancy and the patient presents with bleeding and retained products of conception?
This depends on the severity of bleeding. Obviously, if the woman presents with an acute severe bleed, then you need to go ahead and do a repeat D&C. It's important to consider the possibility of heavy bleeding. You might even consider uterine artery embolization or balloon tamponade to reduce the risk of hysterectomy. If the woman is stable, then you should really discuss the need for a repeat D&C with your local GTD centre. Ideally, you would avoid repeat evacuation if the beta-HCG is greater than 5,000 or in the presence of metastases. If the beta-HCG is under 5,000, then there may be some benefit of doing a repeat D&C. One study of recurrent D&Cs reported 40% of women avoided chemo as a consequence of undergoing second removal with low complication rates. If you're going ahead with a repeat D&C, then hysteroscopy is generally preferred to a suction D&C, and you should keep in mind that the perforation rate is about 8%.
Okay, so next question. What do you do if you have an ectopic molar pregnancy?
So this is usually diagnosed on histopathology, and so typically these patients have already had surgical removal of the molar pregnancy. In this case, you would do the same follow-up as you would for an intrauterine molar pregnancy.
Okay, next question. We said that a partial hydatidiform mole might have an embryo. Is it possible, if you continued that pregnancy, that the baby would survive?
Okay, this is a difficult one, and we really need to differentiate between a partial molar pregnancy and a twin molar pregnancy. It would be incredibly unlikely for an embryo in a partial molar pregnancy to develop until term. These embryos often have triploidy, fetal growth restriction, and hydramnios. They also typically demise before reaching viability. The more common situation would be where you have a molar pregnancy and a coexistent normal twin pregnancy. Prenatal invasive testing for fetal karyotype should be considered in these cases where it's unclear if the pregnancy is a complete mole with coexisting normal twin or a possible single partial molar pregnancy. Women who've had a combined molar pregnancy with a viable twin should be referred to maternal fetal medicine and a GTD centre. Although there's a high risk of miscarriage, about 40 to 60% result in live births. The women should be counselled about the increased risk of obstetric morbidity. Severe complications such as preeclampsia, hemorrhage, and thyrotoxicosis, preterm birth, and malignancy. There is a 40% risk of early fetal loss, a 36% risk of preterm birth, a 4 to 20% risk of preeclampsia. In general, the pregnancy can continue, but there should be increased monitoring for preeclampsia and fetal and maternal well-being. There is a bit of a debate about whether the risk of GTN is increased with a twin molar pregnancy or not. But the Ramscott guideline quotes an increased risk of GTN of 27 to 46% compared with singleton molar pregnancy. A UK series reports that there was no increased risk of developing GTN. In any case, histological examination of the placenta is a must, and the woman should have serial beta-HCG follow-up postpartum.
And finally, who discovered the molar pregnancy?
So hydatidiform mole was first described by Hippocrates around 400 BC. He noticed women who miscarried would pass vesicular-like structures or droplets. At the time, he thought that molar pregnancies were caused by women drinking dirty swamp water, and he named the condition dropsy of the uterus. The terms mole and hydatidiform mole were later coined by William Smellie in 1752, hydatid meaning droplet in Greek. You might remember William Smellie from his other eponyms, the Morrisseau-Smellie Vite maneuver for delivering the aftercoming head of the breech, or the double curved forceps. Thankfully, he didn't name this disease after himself.
Oh my goodness, it would be the smelly mole. Imagine telling patients that. Sorry to tell you this, ma'am, but you have a smelly mole.
And on that note, that wraps up today's episode of GTD. Let's do a final recap for those who zoned out.
Gestational trophoblastic disease is a tumour of placental tissue, and the term includes benign conditions like partial and complete mole, as well as malignant conditions. The incidence is 1 in 1,000, but is increased based on ethnicity and age. Risk factors include age under 15 or over 35, previous molar pregnancy, low dietary carotene, animal fat, or vitamin D, previous miscarriage or infertility, and Asian and American Indian ancestry.
Clinical features typically include bleeding in early pregnancy and typical ultrasound snowstorm appearance. More rare clinical features include hyperemesis, thyrotoxicosis, early onset preeclampsia, excessive uterine enlargement, extremely high beta-HCG levels, abdominal distension due to thecal luteal cysts, and signs of metastatic disease. Management includes ultrasound-guided suction DNC or a hysterectomy, and the tissue should be sent for histopathology, ploidy studies, and P57 testing to determine whether the mole is a partial or a complete mole.
A complete mole occurs when 2 sperm fertilize an empty egg and is diploid. It contains no maternal genetics and so is P57 negative. There's no fetal parts and it has a 15 to 20% risk of progression to GTN. A partial mole occurs when 2 sperm fertilize 1 egg and is triploid. It contains both fetal parts and maternal genes, so it's P57 positive. The risk of progression to GTN is 1 to 5%. After the suction DNC, weekly beta-HCG levels are required until negative for 3 weeks for a partial mole and then monthly for a further 6 months in the case of a complete mole. Avoiding pregnancy during follow-up is important, and ideally you should use any contraceptive but a Mirena.
Don't forget anti-D, referral to a GTD registry, and bereavement support for the loss of a pregnancy. The recurrence rate is about 1%, and so the Ranscourt guideline recommends that all future pregnancies have the tissue or placenta sent for histopathology, as well as a beta-HCG performed at 6 weeks post-pregnancy. The Green Top guideline says that if the woman hasn't had chemotherapy, then this follow-up is unnecessary.
Thanks for listening to this week's episode of the Uterine Sound. As usual, you'll find our summary slides on Instagram later in the week. Find us on the socials at The Uterine Sound, our website, www.theuterinesound.com, or email us at theuterinesound@gmail.com. See you next week.